Hi, everybody. Warm welcome to this session to Oral Society for Parasitology, Australian Society for Parasitology. Thank you. So we had a little problem when I was in holidays doing this presentation. So I'm back to the office now. It's going to be easier for this presentation. So special thanks to all organizers, thanks to Simone, thanks to Deborah, and all others who have created this event. So I'm Mark Bonner. I'm dentist. I've been dentist for 47 years. And I work a lot with microscope, curing periodontal patient. And I've been doing this microscope diagnostic for more than 35 years, teaching about how to cure periodontal disease. So parasite is a very, very important part of the gum disease. So we'll go through that. So I'll start. We don't have much time, so I'll go right on to the PowerPoint. So I'll go to this. Partage, fenêtre. There we go. Partager. Some French sometimes. Okay, so it should be good here. Okay, so we are a little late, 5 days after, but still it's the same presentation I should have done in Tadoussac. So you see my little dog, if ever BB, she's doing some thing. I'll take a little break, 2 seconds for Bibisha. Okay, so most important thing if you want to treat and cure patient is really listen to what patients are asking. So most patients, they want to be cured for gum disease and nobody listen or not many listen to this technique. So it's very important. Patients want to be cured simply. And the most important thing in periodontal disease is biology. So biology of oral microbiota, understanding what is health, understanding what is gum disease or periodontitis. And microscope here is a marvelous diagnostic tool. Many times I could not see the patient. I look at the biofilm and I know where the patient is. So it's really a great diagnostic tool and a great tool to cure patient. Most patient, if not all patient, have parasite. This is really, there really is the common denominator of the gum disease. So you see gingivitis, most of the time is only bacteria, white cell, things like that. And when you get parasite, you have periodontal disease. So working with this microscope, we can cure periodontitis, almost all periodontitis from stage 1, 2, 3. Stage 4, if the tooth are too mobile, you may have to remove the tooth, but you can cure up to 10 millimeter pocket with no problem. So I'll go fast. This is big gingivitis. You see calculus, you see the gum is red. And you see under X-ray, you have calculus around the teeth, around the molar here, everywhere. Those are the little calculus. So this is big gingivitis, not yet periodontitis, no bone loss. If you look at the biofilm here, you have gingivitis, typical oral microbiota. You see the motile bacteria. So spirochetes are very common, some bacilla moving too, and sometimes some Vibrio, but spirochetes is the most common thing. The other thing you see is the remnant of neutrophils. So those are neutrophil nucleus. This is some kind of like pus. So bacteria, Vibrio, spirochete, bacilla, and neutrophil, dead neutrophil with 3 lobe rest of nucleus. So this is gingivitis. Now, what we want is share all this with the patient all the time, all the time. So we have this nice microscope, Olympus, Leica, whatever. It's very good. You can, with the Leica, you can put on the iPad, iPhone, any television screen, show the patient. Important thing is show to the patient what he's having in his mouth. So, doctor, please tell patient what you see. Here's a patient, a cured patient. Big screen here, you have only epithelial cell, no motile bacteria, almost no bacteria. So this is cured patient. So it's quite easy to understand if you have the microscope. Now, during periodontitis, you have calculus, yes, sometimes no calculus, but what you have is bone loss. Here is 7 to 9 millimeter bone loss caused to this periodontal disease. So if we have a look, I'll go straight to the point. You have a look here at 1000 magnification on a microscope. So what you see is motile bacteria, bacilla, spirochete, vibrios, and you have those parasites. So here you have two parasites. The black things are red cells, so it's bleeding a little bit. But most important you see is parasites. So this is Entamoeba gingivalis. You have small ones, big ones. You have the bacteria, you have baby one here, you have another one. So amoeba is clearly present in the same time as bacteria. But amoeba parasite are typical of gum disease. From the time you have parasite, you have those amoeba here, you will have the bone loss. So it goes with it, it's all the time. If you have parasite and no bone loss, in the next 6 months or next year, you will have the bone loss. So it is really all the time present with this gum disease. So you see how it's moving, pseudopod going on. We see the little like road like because those parasites are moving. Here's a baby one. Here's the pseudopod. You have 3 or 4 of them. So it's quite easy to see. And you have to look at the nucleus. Here's the nucleus. Typical is 4 millimeter nucleus with chromatin and karyosome in the center. So this is baby one, this is a small one, and this is the adult one. So you see, we're moving and we find many of them all the time. Sometimes you have to work a little bit. So I'll show you how I do it. I do it with low power searching. So here I'm a little out of focus, but I want you to see I'm looking for those parasite nests at low power. Okay, so it's easier to find those parasites. Sometimes we have big cells. Most big cells are epithelial cell. Smaller cell, round cell are amoeba, and real small cells are a neutrophil, white blood cell. Okay, so here I'm looking, searching, low power, searching again. And there I find, okay, I'll make the focus, low power, looking for parasite. Here I find the nest, okay? So you see here, we have many parasites with the little roads because they're doing channels inside the dental plaque. So when you found this nest, okay, so you see all the parasites here. You go to diagnostic with 1000. So there you see the parasite. You clearly see the nucleus with karyosome in the center and chromatin around and the pseudopod. You see sometimes they move a lot, sometimes they move a little bit. Here's a big one, red blood cell, amine parasite. So it's quite simple to see the pseudopod doing like circular movement, some with lobopod movement, and you see how they make their channel within the plaque. Always some spirochete, some vibrio, some bacilla. Those are the three we see. We see small bacteria with surrounded white space. Those are gram negative. Those are no good bacteria. So here three, and then we go back. Many times I go back to low power, high power, low power, so I can make diagnostic. And so you also can learn how to find, pardon, how to find the parasite. So what you have to do is go low power, high power. You see, here's the dead one. It's very a live one. So here again, you make your diagnostic with nucleus. Looking for the nucleus is the most important thing, because if you have macrophage, macrophage is 12 millimeter diameter, is larger. So here are typical entamoeba gingivalis. So you see the channels. This is the dip displacement within dental plaque at the bottom of the sulcus, diseased sulcus. So it's quite easy to see on low power. And then it's easier to find, and then you confirm your diagnostic with high power. Baby one, mother one, and here again, karyosome and chromatin, nucleus 4 micron, and it eated sometime 5, 10, or 20 nucleus of white cells. So we'll see that in a few minutes. So spirochetes again. So this clearly is active periodontal disease. No, no matter, it's always a pathogen problem. Okay. So I'll go back. So you learn how to do. You see how there's a big one here. There's a round one in the center. So I I don't like to have only 400 magnification. So I prefer to have 100 and 1000. So 100 you can find, and 100, 1000 you confirm here, this big amoeba, you confirm going to 1000 magnification. So there is no doubt it is entamoeba gingivalis, with the nucleus is right here, chromatin and karyosome and pseudopode here. So it's there we go. Now, what about those parasites? Many dentists will look for factors, risk factors, which they say is stress, genetic, or genes, or smoking, or porphyromonas bacteria. I really disagree with all those things, and really I understand that to have periodontal disease, what you have to find first is gingivitis. If you have no gingivitis, you cannot have periodontal disease. So the most important risk factor is gingivitis. From gingivitis, you have bleeding, you have white blood cell, and from this gingivitis, you find some parasites somewhere into around in your environment. Those parasites, they get into the gingivitis, and then you get periodontal disease. So if you want to cure periodontal disease, you have to understand it's not stress, it's not smoking. If you stop smoking, that's good. But what you have to do is remove those parasites, because those parasites, they have a 600 times higher risk for gum disease, and gingivitis is the portal of entry. You know, when you have gingivitis, it opens all the epithelial cell, and then the parasite gets in. So get rid of gingivitis and get rid of those parasites. This is how you cure a periodontal disease. Now, some new microscope, you don't have eyepiece or objectives. Eyepiece is not necessary, but I still prefer to have those eyepieces, because you see 2 times larger. Your field of vision is larger if you look in the eyepiece. But if you want to share with the patient, it's fun to have the screen. So I always have both screen and eyepiece to make sure I see the parasite. So to do this test, I use a microscope slides, and I use cover glass, 20 by 40 millimeter large cover glass. So I can take 3 samples from the mouth and look with the patient at 1000 at 100 to fine, and 1000. You see here, 100 magnification, you are on a pH 3, you are on phase contrast dark field. So bacteria goes white. It's easier to find the parasite on this dark field. So the only thing you have to do is keep pH 3, low power and high power. So it's dark field at low power and white field at high power. You use oil, you just add oil for the immersion microscope. It's quite easy. Don't put anything around the large cover glass because you'll kill the parasite. So just put the saliva and put your sample. I'll show you how we do it in a second. So this is what you see in periodontal patient, typical 30 years, stage 2 or 3. You see the amoeba parasite, you see the bacteria, and you see the neutrophil white blood cell with three-lobe nucleus. Sometimes the third lobe is under another one. So it's clear neutrophil, 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 and the amoeba right here with the pseudopods. So what we do is we take three samples from the patient, three area in the mouth where you have deepest area. So we take deep ones. We take three, one in the each side of the mouth of preference, and deepest one. We put them on the slide, and then we search around this biofilm and looking at it, and then you find with low power, you find the amoeba, you find the nest, and then you go from there. The worst thing you see on the slide is what you have in the mouth in obligation. So what we take is saliva to do the mounting. Never use water, never use serum physiologic or saline because you kill the parasite in the same time. Okay, so this is very, very important. This is the biggest mistake for years and years and years. So you take saliva, patient saliva, you put 3-4 drops on the slide, and then you go in the deepest area, you go with the probe, you go into the sulcus, very deep into the sulcus, just get the plaque from the deepest area on the sulcus, you put it on the saliva, and just take 1 second so you keep everything alive, okay? Pardon me. And then you put the cover slide on top of it. Very important, 22 by 40 millimeters cover slide, so you don't get the oil under the cover slip, okay? So you press firmly with a 2x2, or, so it is, you press hard, very firmly, so it's thinner. The thinner it is, the best you will see your sample. So I always take with all patients 1, 2, and 3 deep area to make my diagnostic. Okay, and anything with parasite will be considered positive for periodontal disease. Pardon me. So when we see this is typical patient with 20 years of deep cleaning. So most dentists, periodontists, hygienists, they do deep clean. So deep clean is, it removes some calculus, but it does not remove pathogen oral biofilm. You only remove 15% of pathogen biofilm with deep cleaning. So deep cleaning is like no good. This typical patient, 20 years of treatment, deep cleanings and deep cleaning, and I look at this patient 20 years later, you see the amoeba always presents, parakeet, Vibrio bacilla, white cell. So deep cleaning is not a real good treatment. You have to remove this. And the problem is dentists, they don't have the microscope. So have a microscope and show this to the patient. Any patient will understand this is not possible to keep those parasites, those pathogen bacteria are no good. It's quite clear, but you have to have a microscope. So please don't say microscope is no diagnostic. Everywhere in medical field, microscope is diagnostic tool. So don't leave this into the patient mouth and inform the patient until he is cured. Okay, so biofilm is really organized. This is a little drawing I made during my seminars. So if you want to look, here is the crown, deep area. But when you are in health, you only have dots and lines, cocci and filaments, bacteria. That's it. Okay. So this is plaque. Sometimes it's longer bacteria, longer filament, but it's only dots and line, cocci and filament and long filament. This is health. Now, if you have this plaque for too long or for any reason, other reason, um, you will be in gingivitis. So gingivitis, you have those mostly are parakeets, sometimes vibrios, but mostly it's parakeets. And you have if you have too many of those bacteria, motile bacteria, then you have neutrophil here in red, I showed in red. You have those neutrophil coming in. So this is gingivitis. Now, gingivitis is the entry of periodontal disease. Why? Because when you have this gingivitis here, you have the parasite coming in from the water, from another person, from food, kissing the dog, whatever. Okay, so you have those parasites. Why? Because those parasites, they feed on the nucleus of the neutrophil. So you have some parasite in the water, they get into your gum disease, gingivitis, and then those parasites, they love it because they feed on the neutrophil mostly, sometimes bacteria, but most activity of those parasites, Entamoeba gingivalis, is feeding on the nucleus of the neutrophil. So they feed, they make babies, and they do nesting. And sometimes you have actinomyces, long filament, and those long filament, very active long filament with a lot of motility of the bacteria, they just go under this filament, which will be calculus, black calculus on a long period. And then you have those parasites getting under it with no oxygen. So they love it, they do babies, and then you have calculus, nesting of those parasites. And those parasites, removing the nucleus, they just liberate enzyme that will destroy the bone under it. So it's quite simple to see, it's quite simple to understand and see the stages from health to gingivitis and to periodontal disease. So it is really easy. So our model is real simple. You know, this is health, dots and line, cocci and filament, non-motile bacteria. This is health all the time. And you'll find epithelial cell. If you take some plaque from the sulcus, you'll find epithelial cells. So this is very easy to see and confirm. Here we have filament and cocci. This will be calculus, supragingival calculus. But no real problem if you remove it from time to time. So this is health on the microscope, 1000 magnification. If you have plaque, too much plaque, or trauma, or systemic disease, or whatever, then you have gingivitis. In this situation, you have more spirochetes, motile bacteria, and then you have neutrophil coming in. So they're helping your body for defense. But if you don't clean this gingivitis, if you don't get rid of it, which normally is quite easy, then you find on your road, you find some amoeba, Entamoeba gingivalis, or sometimes trichomonas, which are very aggressive parasite. So from the gingivitis, you have those parasite and red complex, of course, with it bacteria, and then you have those parasite eating the nucleus of the white cell neutrophil. So there you are having periodontal disease with bone loss. Now, if you want to cure this disease, it is quite understandable. You just go back to normal oral microbiota. So you have to remove those parasites, you have to remove the pathogen bacteria, you have to remove neutrophil, macrophage, and then you go back to cure. Now it's easier to remove the microbes and then the calculus because there's no more inflammation. So do remove the microbe first, then calculus, and then you're back to health biofilm. So sometimes when I explain, you have those long filaments with bacteria active. You see those parasites nesting under this bacterial filament, very active actinomyces filament. So this is good patient with recession, but under those little 4 or 5 millimeter pocket, you find this. So don't keep this in any patient because they will do babies and it will be worse after some time. Now, make sure you have a good diagnostic, but that's not the biggest problem. Just make sure you understand this is neutrophil, 15 micron. This is macrophage with large nucleus, 12 micron here. This is macrophage. Many times we see it to remove debris and remove calculus or remove other things. And then you have the amoeba here with the nucleus, 4 micron, karyosome, and chromatin. So make sure you understand those three things. But if you remove everything, it's okay. You want to remove neutrophil, you want to remove macrophage, M1. Sometime after a couple of months, you have M2, you're having more bone construction, but start removing neutrophil, macrophage, M1, and amoeba parasite. So what we do with this microscope, we call it fresh smear examination of a fresh smear saliva. So we understand the presence of microorganism. We understand general morphotypes. Some say it's only morphotypes, but morphotype is as eloquent as a name of bacteria. If you have 200 bacteria or 800 bad bacteria, it's not problem. We want to look at general morphotypes. It's the same thing as giving a name to a bacteria. What we don't want is motile bacteria, motile protozoan. Okay, so remove them. Remove inflammatory cells. This is what we see. Sometimes yeast or candida. We can see this. We can remove it. Sometimes you have vibration, Brownian movement in neutrophil. This is normal. Sometimes you have saliva going from place to place. It's not the real diagnostic, but see presence of microorganisms and understand the good and the bad ones. So the good ones are dots and lines, cocci and filament. Those are the green complex. Sometimes Leptotricia is longer ones, or Cocobacilla. Cocobacilla are not bad, but sometimes you have Porphyromonas, which is also Cocobacilla. So you can do a test, DNA test, but with the microscope, this is quite easy. This is health. This is health. And from the time you have Bacilli, Vibrio, and Spirochete, then you have gum disease, gingivitis. And from there, you have neutrophil and macrophage coming in. And then you have parasite, Entamoeba gingivalis, and Trichomonas tenax, sometimes Candida. So we see all this on the microscope. So we've made a little drawing again to understand the good ones. So cocci, filaments, non-motile ones, those are the good ones. Leptotris is longer filament. It's just telling you you have more the plaque for more longer time. And so we keep this, there's no problem. From the time you have spirochetes, bacilla, and vibrios or other streptococci, but most of the time spirochetes, longer ones, smaller ones, bacilla, very active, and vibrio going like this, you are in gum disease. Now, from this time, you have neutrophil, you have bleeding, you have white red cell, and then you have white blood cell. So most of the time, this is neutrophil, and from there, you have the parasite eating the neutrophil. If you're in big problem, one-third of periodontal disease, you will have a second parasite, which is Trichomonas here. So Trichomonas tenax is very aggressive and will destroy the epithelial cell and get into the gum, and you create some problem. Another way to look at it is another drying, which is this is health bacteria, dots and line, cocci and filament, sometimes association, which make supragingival calculus. And this is normal, healthy to everybody. Everybody has the same thing if you are in good health. Now, if you have those bacteria coming in, spirochete, bacille, and vibrio, then you have gingivitis, and from there you have neutrophil coming in. And then you find parasite on your way, and those parasites eat the neutrophil, and they leave what we call ghost cell here. So those neutrophil with no nucleus, they just release proteolytic enzyme, collagenase, etc., all those things. And this goes into the collagen fibers and bones. So this just destroy the bone. We could say also porphyromonas here or AA would be present. Yes, it also destroyed the bone, maybe, but those parasites, neutrophil, and all those bacteria are so quite easy to see and understand. So we show the patient. If you destroy, remove those parasites, amoeba and trichomonas, porphyromonas and AI will be resolved in the same time. So it's quite easy to understand from left to right: green complex, yellow complex, orange complex, and red complex with parasite and sometimes candida. So you just have to get rid of it. Sometimes Neisseria, Veillonella, or Gardnerella don't keep this on the microscope either. So curing the patient is quite simple. It's just remove those orange, red, yellow complex parasite, and then you have to be cured. It's just harmony. It's just normal biofilm. Just keep green complex, and then all your patient will be cured. So what you have to do is look at the patient every appointment. Our treatment is typically for a complete gum disease, periodontal disease, about 10 appointments. But if it's small stage one, it could be 5 appointments. But look at your patient on the microscope every appointment. Do not leave any parasite, no amoeba, no trichomonas, no spirochetes, no vibrio, no bacilla, no white cell. If you remove all this, you treat the patient and you cure your patient. So, pardon me, we call it Bonner method because many patients ask for our name on internet and many places. So we call it Bonner method now. It's easier to find for the patient. So typical same patient that we had before, 30 years old, patient with periodontitis. Look at this. You have amoeba here, amoeba, 8 of them. You have ghost cell here. The amoeba just eaten the neutrophil, the nucleus of the neutrophil. So it's quite easy to see, confirm, and diagnose. So this is an amoeba with nucleus here, 4 micron nucleus, and inside the amoeba you see the nucleus of the white cell they have eaten. So you see how they do, long or large pseudopod. This is only saliva with spirochetes within it. So we know it's not good. So if you look at the film, typical film of this patient, you'll find the amoeba with the pseudopod, a baby one here. I call it minuta. So you have baby amoeba, mother amoeba, baby amoeba, and you have those neutrophils. So neutrophil is like when it dies, it's like pus. So pus, amoeba, bad motile bacteria. This is periodontal disease. So you have to remove all this to to get your patient to be cured. So it's quite easy. So this is medical nonsense to keep this with the patient. Medical nonsense to keep those parasites in the patient's mouth. Those are aggressive parasites. Why are they aggressive parasite or pathogen parasite? It is because they feed on the nucleus of the white cell. So this is neutrophil here. The amoeba just goes to the neutrophil. It does stop the activity of the neutrophil. It's just like it bites the neutrophil. Then the neutrophil is not moving anymore. And from there, you don't see the granules anymore. And from there, the amoeba send the pseudopod into the cytoplasm of the neutrophil and take the nucleus. It's like those are the proteins to feed the amoeba. And you see this process we call exonucleophagy, just feeding on the nucleus. It just get this nucleus inside the amoeba and then just make a little round of it. And this is one and two nucleus that was eaten earlier in the day. Okay, so nucleus, two nucleus of white cell, and this is the nucleus of the neutrophil. So this is why it is clearly a pathogen. You see here almost the same amoeba, but almost finished the three-lobe nucleus eating it. So the neutrophil cannot defend yourself anymore because it's like you cut the head of the neutrophil. No more nucleus, no more activity, normal activity of the neutrophil. So sometimes when you have many neutrophils that have been eaten, you'll find those round cell, which we call ghost cell, with no nucleus, no granule, and all those enzymes are spilled on the tissue, elastase, collagenase, and then you have the bone loss. This is very easy to understand for the patient. Okay, you have bacteria, you have neutrophil from there, and then you have parasite eating the neutrophil, and from there the ghost cell, those neutrophil, send proteolytic enzyme on the tissue and break the collagen of the fibers and collagen part of the bone. So it's quite easy to understand. The amoeba also can feed on red cell, makes a smaller line to feed on the inside of the red cell because they feed on the iron in the same time as protein of the neutrophil. Sometimes you have this uropod at the back of the parasite, and they just take the red cell and go with their lunch, find some other thing to eat. So this is very aggressive pathogen behavior. Have you see how the parasite is doing a baby one here, baby one separating from the mother, and you see eating the inside of the red cell. So this is normal red cell. This is a red cell that was eaten here by the parasite, amoeba, eating this little line, and then you have, when you have real dark spot, little spot here are the red cells that have been eaten by the parasite. Okay, so erythrocyte is inside of the erythrocyte is phagocytized by the amoeba. So you are the food when you have periodontal disease. Your red cell, your white cell is the food of those parasites. So very aggressive, up to 15, sometimes 20 nucleus have been eaten here. This is a big one I put on Wikipedia. Nucleus, typical nucleus, 4 micron, chromatin and karyosome in the center, 4 micron diameter, and here's a nucleus of more than 15 neutrophils that have been eaten. So don't keep this, it is aggressive pathogen. And with the help of some other dentists, Dr. Ramon, Dr. Renier, we found those parasites with 4 pseudopod in the same time. So four pseudopods is quite aggressive. You see it's eating neutrophil of white cell here, eating a second one, a third one, a fourth one. So this first premiere in the world, I would say, about those parasites, Entamoeba parasite, feeding on four nucleus at the same time. So we see this sometimes. So this is very, very aggressive parasite. Do not keep this in patient. So sometimes it is very active. You see when it is very active, see a lot of motility of the bacteria, and you see the parasite doing babies and living under those bacteria. So it goes with the bacteria. It's like a little fish in the anemone, okay? It goes inside here. So you see how those parasites, they love to live with those bacteria under the future calculus, and they do baby nesting, and then you have more and more and more. So do not keep those bacteria or parasites. Now, periodontal disease, it's like 50% of the population at middle age. But if you are 70 years old, it's mostly 90% of patients have periodontal disease. So we need dentists, hygienists, dental hygienists, nutritionists. We need everybody to help understand not to keep this gum disease. So it's not possible. Sometimes you have trichomonas, a second infection. It is one third of the periodontal disease is trichomonas, sometimes trichomonas and amoeba in the same time. So we have a look, low power, we look for parasite or trichomonas. I find an interesting area. And here you have spirochete, Vibrio, Bacilla, our three bacteria, and then you find trichomonas, very active trichomonas. So this is aggressive periodontal disease. So you can lose bone in 1 year, deep pocket. So do not keep those trichomonas. So it's quite simple to see. See many bacteria. This is not normal. Motile bacteria, white cell, and here you have trichomonas on the right side. You see they have four flagella and they go like this, very aggressive trichomonas flagellate parasites. So do not keep those trichomonas anytime. It is very aggressive pathogen. So if we have a look here, you have neutrophil on top, and you have typical activity of this trichomonas at 1,000 magnification. So nobody wants that. So do not leave those trichomonas in the mouth of your patient. Don't. Go back to health. So this is healthy biofilm, oral normal biofilm. So you have cocci and filament, non-motile cocci and filament. With patient, I say dots and lines, not moving bacteria and epithelial cell. Epithelial cells are something like 85 micron, and you have larger nucleus here, about 12 microns too. So this is normal biofilm, dots and line, cocci and filament. So if you go back to this abiotic biofilm, you have to be cured. It goes with cure. Okay, so if you have this, you have cured patient. Okay, if there is calculus, you did not remove calculus, you will have macrophage present and neutrophil present. If you have no more neutrophil, no more macrophage, no parasite, no motile bacteria, you have to be cured. So this is why I'm so excited to speak about curing periodontal disease, not stabilize, not, we want complete health and to be cured. So I've published some or many articles, five or six with peer review, actual peer review from dentists and periodontists. So this is our technique we call Bonner method, and it's quite simple to understand. First phase is disinfection. remove bacteria, remove parasite, remove white blood cell. Okay, so this technique we use hydrogen peroxide 1% for brushing, and then after 1 month, 2 months, this is like 12 months, we use Torrance powder. Torrance powder application on the gum line. This is baking soda and salt. So you'll find this on the internet. Torrance powder, baking soda, and salt. You can just put a little bit on the gum. This is what Egyptians used to use for brushing. So it kills the parasite. Salt is the best medication to kill parasite. They explode with osmotic change. So use hydrogen peroxide will bring oxygen to the tissue, to the bad bacteria. They don't like it. Same for parasites. So start with hydrogen peroxide brushing, 1%, then add Torrance powder, and you keep this for 1 year. And you all your patients be cured. But sometime in stage 3, you have to help destroy the parasite. So um, you can put metronidazole in the fourth month to kill the parasite. I can use also topical metronidazole. Why metronidazole? Because metronidazole is the antiparasitic drug. So it's not to kill the bacteria while it still is good to kill the bacteria, but metronidazole or flagyl is made to kill the parasite. So we know this medication for 70 years, and it's very good, and there is no resistance to metronidazole. So use metronidazole if you still have parasite after some months. And when all those pathogen microbe are gone, then I remove calculus from quadrant to quadrant. I take 4 months because all the time dentists are doing too fast. To have bone rebuild, it takes about 1 year. It takes 12 months to have the bone regrow. So if you do this treatment in 2 months, you won't have success. You only have 20% bone regrowth. So it takes 1 year to have this bone to grow back in vertical defects. So take your time. And what we do is seeing this patient like 10 times, we see with the patient to have perfect autonomy. So every time I see the patient, we take 20 minutes to see for flossing, see how to brush, bass modified with the product, how to put the product on the gum, and we go quadrant by quadrant. Pardon me. And every appointment, we just do cleaning everywhere. One quadrant, clean everywhere. The other quadrant, cleaning everywhere. And teaching with the patient how to be perfect hygiene. If you have perfect hygiene, no more periodontal disease is possible. Why? Because no gingivitis. Okay. And we discuss also contamination. So no contamination is needed. Do not kiss the dog. Watch for tropical water. So where there's parasite in the water, or when you drink, when you shower, uh, just make sure your husband and wife, your spouse, is not having periodontal disease too. So get cured, both of you, if you have periodontal disease. You say spouse at the same time, and do not keep the dog. Don't kiss the dog. Wash your hands. Don't kiss the dog. If the dog, most of the dog have parasite, have trichomonas and amoeba in their mouth after 3 years old. So wash the dog, wash the water, watch your spouse, and make sure to have perfect hygiene. If you do all this, it's not quite difficult. And then we take this third phase is like 3 to 4 months to have the bone regrow while we have perfect microbiota. So this is how we go to complete health, usually after 1 year. And from there, we can keep hydrogen peroxide, baking soda, sometimes 2 times a week, but for life. Okay, so if you ever get some parasite, you kill them every week. So 2 times a week minimum. if you want to make sure have no gum disease. So another way to look at our method is this is like an initial problem, like 9 or 10 millimeter pocket. We can cure up to 9 and 10 millimeter pocket. It goes back to 3 millimeters. So first thing for first month disinfection, you remove the parasite, remove the bugs, remove the pus, remove some calculus, external calculus. At month 5 to 8, we remove calculus in perfect abiosis. No more bacteria, no more parasite, no more neutrophil, and then we remove calculus. It is really easy to do when there is no more inflammation. Okay, no bleeding, no inflammation. Then we remove calculus for appointment, make sure everything is fine. And then some healing time, 3 to 4 months, and keeping this abiosis in time. If you do this, the bone will regrow, the gum will recede a little bit, and this is both things, a little regression of the gum sometimes, not all the time, and the bone will regrow back to the gum. So we close all pocket up to 9 millimeter, 10 millimeter pocket. We go back to 3 millimeter after 1 year. So this is cure. If you are cured, this means no pocket, no bone loss, no pathogen microbe, then no more periodontal disease is possible. Another way again to look at the treatment. This is first appointment, second, third, fourth. Okay, this is disinfection. What we do, always listen to the patient, X-ray, charting, everything. We do floss meter. We ask patient to smell the floss to make sure there's no infection. Patient can do this at home. And we teach how to do the hydrogen peroxide brushing. This is stage 1, 2, 3, or 4. So you find this little round circle to know how to treat this patient. Like stage 2 will be only the dark yellow. So this is 4 appointment, 2 appointment removing calculus, and 2 appointment for make sure this is complete and cured. Okay, so yes, this is typical treatment. If you have stage 4, I will start with metronidazole up first. If it's stage 3, sometime I will use metronidazole at the 4th appointment to make sure everything is fine at 5th appointment, so we can remove calculus in a normal abiotic area. So this is how we make sure we cure all patients. So we've published this. This is publication of mine in 2024. Our last 20 patients, because I am retired now and just teaching, but this is our last 20 patients on a row. All 20 patients cured. So curing is quite simple. No pocket over 3 millimeters. You only want 1, 2, 3, 1, 2, 3, 1, 2, 3. No bleeding, none, no bleeding. No dysbiose, no bad bacteria, no parasite, no inflammatory cell, nothing of this, and perfect hygiene. This is cured patient. So what we've published is excess of pocket dents. So 1, 2, 3 is 0. If you have 4, 5, 6, it's 1, 2 plus 3. It's you have 500 millimeter pocket over 3 millimeter. That's initial patient. And when we're finished at 1 year, no more periodontal pocket over 3 millimeter. This is what we want, what we do curing the patient. Same for no more bleeding. Bleeding here, 100% bleeding, and at the end, almost no bleeding. This is what we want to have complete cure. And we know with those patients, this is pocket depth. So this is what we've published on the 20 patient. If you have a pocket depth of 7 millimeters, it does finish at 2.9 millimeters. 10 millimeter pocket will finish at 3.2, almost perfect. 9 millimeter pocket will finish at 2.8 in our study. So no more deep pocket. If you only do deep cleaning, you'll have like this. You'll have a 8 millimeter pocket will finish at 5. So the line will be like this. So this is no good. What we want is almost all the time under 3 millimeter pocket. So this is what we want. So this is before and after. Typical patient with 6, 7, 8, 9 millimeter pocket. See, you see the bone before treatment, bone loss. Periodontist want to extract, remove teeth, and do a implant. I say no, no, no. Let's cure this patient. And you have after treatment, Bonner method. You have no more pocket. 2, 3, 2, 3, 1, 2, 3, and you see bone is getting back, filling the area of vertical defects. So see before and after. So the bone will grow by itself. No need to add bone, no need to add powder or anything. Just go back to normal microbiota and the bone will grow back again. Remove calculus, of course, but remove the bad microbiotic biofilm. And it is quite important now because we understand very important link with Alzheimer's disease, dementia, severe periodontitis will increase Alzheimer's risk by nearly 7 times. So this is research. This is journal of periodont of Alzheimer and dementia, saying watch it because gum disease is linked to Alzheimer's disease. And if you look into your family or older people, you'll see that, and you have some studies about this, sadly, but our old grandfather, grandmother, they removed their teeth when they were young, at 20, 30 years old. They removed their teeth, they have full dentures. But what happened to those patients is like they have no Alzheimer's disease, no gum disease, no Alzheimer's disease, no gum disease, no periodontitis is linked with no Alzheimer's disease. So it's time to talk about this. It's time to cure your patient now. We don't want gum disease, we don't want periodontal disease, and we don't want dementia or Alzheimer's disease. So nothing to lose, just cure your mouth, cure your periodontal disease now. This is important. So we have our books in French, in Spanish, in English. It's called To Kiss or Not to Kiss, A Cure for Gum Disease. Thanks to Deborah, has her books now about this treatment too. So you can cure your patient now. You find everything in our book, To Kiss or Not to Kiss, A Cure for Gum Disease. It's been published for a long time in French and use the microscope. Also, you will find our treatment protocol. So Bonner method was called Periodontal Healing Protocol. Bonner Dunoyer, which was our director of school director. So Periodontal Healing Protocol, you'll find PHPBD. You'll find on internet. This is 100 pages. You'll find all treatment. This is free. You can find it anywhere on internet. Otherwise, parodontite.com, parodontite in French.com. But if you write PHPBD, Periodontal Healing Protocol, you'll have all these 100 pages, and it explains you how to do the treatment step by step, appointment by appointment. Also, you find ResearchGate, our more than 25 studies we've published or any publication. Look at dentistry and oral maxillofacial surgery, Octores publication. You see all the parasite here. I explain all those parasites are pathogen and do not keep those, please. So the essential thing you will find on PHPBD, Periodontal Healing Protocol, Bonheur du Noyer, you'll find those important things, which is periodontal charting. So every 12 months, we take all patient, we do periodontal charting to make sure it is cured. No more pocket, no more bleeding. When we do the treatment, we use what we call periodex. So it's this page here where you find medical of the patient, clinical area, and you have the microbiology of this patient. So we call it periodex, paradex. So you find everything in there in this PHPBD essential. We also have a treatment, complete full page treatment and patient file, the same thing. So you have treatment phase, treatment first visit, second, third, fourth, all up to 12 visits. And you can write what you find about bacteria, parasite, white blood cell here on the right side, and complete treatment. On the 2 pages, you have full treatment. And what we recommend to all dentists, hygienists, and periodontists is to have like patient have patient complete treatment. See, so we want this fill with no more parasite, no more bacteria. So I hope this answer many points about parasitology, oral parasitology, periodontal disease, and linked to parasite, pathogen Antramoeba, gingivalis, and pathogen Trichomonas tenax. So thank you for your interest. I hope it does help. And always ask if your patient, always ask your doctor for microscopy, always ask for periodontal cure. If your dentist, dental hygienist, or periodontist, just learn how to cure a periodontal disease. So we still are doing some seminars in Paris with Sana Oris, sanaoris.com. You'll find in Paris 2 or 3 times a year. We'll still do this seminar. It's 3 day, 4 days seminar to learn how to cure gum disease. So thank you for your listening. We like to answer questions, and but we'll be present after this live. And if you have questions, just write question, and we'll answer this presentation. So thank you. We were supposed to be in Tadoussac. Now I'm back in the office, but it's okay. So thank you very much, and hope you find cure with all your patients. No more parasite in the mouth. Thank you very much. So I'll stop partage here. Arrêtez le partage. Okay, so thank you very much. Take care. Get cure of your periodontal disease, and if you're dental hygienist, I think you can do so much. If you're a nutritionist, if you're a naturopath, you can help patient having no more parasite and getting cure of periodontal disease. So thank you very much, and take care and have good health. Thank you, and bye-bye.